Today we're going to go over our stroke evaluation. Normally we start with a tool like the Cincinnati Stroke Scale, which is a very simple way of screening for stroke. It's not adequate in and of itself because it misses 20 to 30% of strokes. But I'm going to go over the Cincinnati Stroke Scale, and then we're going to go over some of the other things that we add to our stroke examination to make sure that we don't miss any strokes out there. Really, the way these stroke evaluations work is we're looking for deficits in brain function. When you have a stroke, an artery to a certain area of the brain gets obstructed or breaks and starts to bleed, and the area of the brain that gets fed by that artery becomes dysfunctional, and it gives you the stroke symptoms. The Cincinnati Stroke Scale looks at a lot of the arteries, a lot of the territory that the circulation supplies to the brain, but not all of them, which is why some stroke symptoms are not picked up by the Cincinnati Stroke Scale. But it is a good tool to start with. So the first thing we're going to do is take our patient here and go through the Cincinnati Stroke Scale. The first thing we have is, Sarah, I'm going to have you just tell me how are you feeling today?
Feeling good.
And tell me what year it is.
2016.
All right, so you just want to start with your basic mental status examination. Generally, folks lose date first, so you can usually start with a date question. If they know what year and month it is, it means they're almost certainly going to know their name and where they are. So your usual AVPU scale is good enough for that. And then we go right into the Cincinnati Stroke Scale. So I'm going to have you just make a big smile for me. And so what we're going to be looking here is for symmetry. When you're looking for stroke symptoms, you're looking for asymmetry between the sides. So we're going to look here to make sure that you can see the same amount of teeth on both sides. You're going to look at what's called the nasolabial fold, which is this wrinkle that goes from the edge of the nose to the corner of the mouth, and make sure that they're equal on both sides. You can relax a second. So one of the things we're looking for is asymmetry. For folks that are having a stroke or Bell's palsy, you'll see one side of the face will move well and the other side will not. We can show a picture here that you'll see in the picture that on one side of the face you've got a very deep nasolabial fold, and on the other side the nasolabial fold is much more soft, almost as if the patient received Botox. And the way the Botox treatments work is when a patient is injected Botox, it paralyzes the underlying muscle, and it makes the wrinkles less significant, less deep on that side. Stroke does much the same because you get paralyzed muscles in a stroke. So what you'll see is a less deep wrinkle on one side versus the other. And that's how we can pick up more subtle strokes. Major strokes are a little more obvious, but subtle strokes, you'll see the face can move on both sides, but you'll see a difference in the size of the wrinkles. To tell the next step in the Cincinnati Stroke Scale is going to be have the patient lift his arms up, and we're going to be looking for what's called pronator drift. And you want to perform this with the palms facing towards the ceiling. You can try this yourself. Putting palms down is a lot easier than palms up. And again, it's designed to pick up more subtle sorts of stroke. You should do this with the patient's eyes closed. And what you're looking for, a positive finding would be if the patient's one side starts to turn in, this is what we call pronator drift, or if it actually drifts down. So if they can't lift it up to begin with, or it turns in, or starts to drift down, then that's a sign of a stroke. If they both drift in or both drop down equally, that's not a stroke, that's just weakness, and you can relax. Again, we're looking for asymmetry between the sides, so one side being different than the other. The next part of the Cincinnati Stroke Scale is the test ability to repeat a sentence. And this is a very efficient neurological exam because it measures multiple brain pathways all at the same time. Typically, people ask patients to repeat, "You can't teach an old dog new tricks." There's nothing special about that sentence. You can have them repeat anything you like, or just even have them count to 10. The point is, you want to measure the patient's ability to hear the sound, convert the sound to intelligible speech in their brain, create a thought to respond to that, and then have the complex muscles of speech produce a clear sound. Any alteration in that pathway, either they don't respond, they give you slurred speech, they give you wrong words. All of those are potentially a stroke. So I'm just going to have the patient count to 10 for us. Go ahead and count to 10.
1, 2, 3, 4, 5.
And that's fine. So he heard me, he understood the command, he was able to produce the speech in a nice, clear manner. Now that is basically it for the Cincinnati Stroke Scale. Now I'll pick up 70 to 80% of strokes, but we need to go beyond that because there's certain areas of the brain that are not tested by the Cincinnati Stroke Scale. So the next thing you want to do when you're adding to the Cincinnati Stroke Scale is cranial nerve assessment. The cranial nerves are basically supplied by the posterior circulation of the brain, and they include things, basically your eyes, movement of the eyes, vision, things like that. Facial droop is actually controlled by a cranial nerve, but that's only one of the several cranial nerves. So what we're going to do here is we're going to check the patient's ability to track an object. So what we do is looking at the patient's eyes, go ahead and face that way, just look at, you hold a finger in front of the patient's face, and you have them track it with their eyeballs. and you're looking off to the side. And as the patient's looking off to the side, you're looking at the eyes to see if the eyes are shaking from side to side. That would be a sign of nystagmus. Nystagmus is a shaking from side to side. And you got to go up and down. So you're basically making a T, side to side and up and down. You make sure that the patient can track the eyeball. And you're looking for shaking of the eyes, and you're looking for the patient's ability to actually follow that command. So the next thing we're going to do is we're actually going to do visual field testing. Sometimes when patients have a stroke, they lose the ability to see one side of their visual field. And they may not actually be aware of this. One of the things you may see looking at the patient is they may have their eyes deviated off to one side. Let's say, for instance, you see a patient and they're looking only to the left. That's a good indication that they can't see the right side of their body, because patients who have visual field deficits are not actually necessarily aware that they actually cannot see on one side of the body. The way to test for that is you have the patient cover one eye, so go ahead and cover your left eye, sir, and look directly at me. And you're going to have them look straight in the center of your face at your nose, because you're testing their ability to see off to the sides against your own ability to see off to the sides. And there's two ways to do this. You can hold up a finger and say, how many fingers do you see?
One.
Or how many fingers do you see?
Two.
And really, it's not so important that he gets the correct number of fingers, it's that he can see both sides. Alternatively, instead of having him count fingers, you simply hold up both hands and say, tell me which side is wiggling.
Both. And
you can do that, alternate it with the other eye as well. The point is you want to make sure that he can see off to the side in both sides, and then you would switch it for the other eye. The next thing we're going to do is look at cerebellar function. This is an area that is not tested by the Cincinnati Stroke Scale. Cerebellar function is another area of the posterior circulation of the brain. It's different from our cranial nerves, and it's basically testing the patient's coordination. One of the simple ways to do this is when the patient is in the pronator drift position and with their eyes closed, touch one of their fingers and tell them to touch their nose and put their hand back where it was. And then you can do the same on the other side. And that's your basic finger to the nose test. Now, if you can open your eyes and relax. A way to make that even more sensitive, to pick up more subtle strokes, is to do what's called the finger to nose to finger test. In this case, what you're going to do with their eyes open is have the patient touch their nose with one finger and then touch the examiner's finger. So again, touch your nose and touch mine and go back and forth. So this finger, and then you're going to switch that to the other side. And what you're looking for is asymmetry. So if the patient is able to do this right on the nose both sides, that's great. But if they do this on one side and this on the other, that's a sign of cerebellar dysfunction on one side, and that's positive for a stroke, or potentially for a stroke. So continuing with the cerebellar function, just like you do cerebellar function for the upper extremities, you can do the same thing for the lower extremities. In this case, we're doing what's called heel to shin. So what we do is we take our patient and we have them put the heel of one foot onto the knee of the other and run it up and down on a straight line along their shin. And then you would have them switch on the other side. And what you're looking for is for the leg not being able to make a nice straight line there. And again, it's all about asymmetry. If the patient is equally bad both sides, it's not a stroke. But if they're able to do one side nice and smoothly and the other side is dysfunctional, that's a sign of a cerebellar infarct. And the last couple of things we need to do is motor function and sensory function. The Cincinnati Stroke Scale does do the motor function of the upper extremities, but it doesn't even look at the motor function of the lower extremities. And there's a type of stroke when you have an obstruction of the anterior cerebral artery, where the only symptom you're going to get is weakness of the legs. So this is one of the types of strokes that the Cincinnati Stroke Scale will miss. The way to test this is very similar to doing the upper extremity motor exam with pronator drift, but you're going to do it with the legs. However, you're going to do it with one leg at a time. So what you do is you'll have your patient lift one leg up in the air and have them hold it about 30 degrees off, and you count to 5. 1, 2, 3, 4, 5. Then you repeat on the other side. And really what you're looking for here is if one side cannot, either they can't raise it at all, or they can't hold it up for the full 5 seconds, it starts to drift back down. Just like you're looking for pronator drift, you're looking for drift of the legs in this as well. So if you have unequal strength in the lower extremities, that's indicative of a stroke. There's a caution though. A lot of our older patients have had hip surgery. And you can get sort of semi-permanent weakness in the lower extremity after hip surgery. So if there's an explanation, a previously existing explanation for isolated side extremity weakness, then that could be a reason why it's not symmetrical. So given that, if they've not had some reason for asymmetry, if you see one side that they can hold up for the full 5 seconds, the other side they either can't lift up at all or they can't hold for the 5 seconds, that's indicative of a stroke. And the last thing we want to do is sensory testing. Again, it's another area where the Cincinnati Stroke Scale doesn't measure. The way you do this is very simple. It's something called the light touch test. You have the patient close their eyes, and you touch one side of their body, and you ask them, where are you touching?
Right forearm.
And then you repeat it on the other side.
Left forearm.
And then you're going to do the simultaneous touch test, and you touch both at the same time. Where am I touching you?
Both forearms.
Now, he correctly identified as touching both at the same time, but there's a type of stroke where when you touch both at the same time, they only notice one side of their body. Now, it's a sort of a curious stroke symptom where the patient, the sensory input extinguishes when you do the simultaneous touch test. So if I were to touch both sides and he only identifies one side, that's actually a type of stroke. You would repeat this examination for the legs and then for the face as well. So just as a summary, when we go through our stroke exam, what we're really looking for is a difference in one side of the body to the other, and we're going to be doing the entire Cincinnati stroke scale. Then we're going to add to that our full cranial nerves. You might want to add pupillary reflexes if you have a light. You're going to add the motor for the upper extremities as well as motor for the lower extremities. You're going to add the sensory, and you're going to add your cerebellar findings such as the finger to nose and the heel to shin. And if there's abnormality in any of those modalities, then we have to consider that stroke as one of the possibilities. Okay, now we're just going to do the full stroke evaluation in real time so you can see how quick it is. Sir, just tell me what year it is.
2016.
Good. Count to 10 for me, please.
1, 2, 3.
That's
4.
good enough. Make a big smile for me. Good. Now let me have you put your arms straight out like this for me, palms up. Very good. Close your eyes. Touch your nose with that finger for me. Good. Touch it with that finger for me, please. Good. That's fine. Now open your eyes for me. Go ahead and touch your nose and touch my finger for me. Good. Do it on the other side for me, please. That's good. Now look at my finger. Follow it with your eyes. Good. Now I want you to look straight at my nose. Cover one eye for me. And tell me when you see the fingers wiggle. Which side's wiggling?
Both.
Okay. Switch eyes for me now. Which side's wiggling?
Left.
How about now?
Right.
That's fine. You can relax. Now what I want you to do is lift this foot up in the air for me. Leave it there for a count of 5. 1, 2, 3, 4, 5. Switch your legs for me there. 1, 2, 3, 4, 5. That's fine. Now I want you to take this heel, put it on that knee, and run it straight up and down for me. That's good. Switch legs for me, please. That's fine. Now just close your eyes for me, and I want you to tell me where I'm touching you.
Right shin, left shin, both forearms, both sides of my cheek.
Very good. And that's all there is to it.